Good morning, all. I'll be talking about periodontal regeneration. Moving on to the introduction, healing processes of all forms of periodontal therapy is same, which is one is regeneration and another one is repair. Ideal goal of periodontal therapy is regeneration of lost tissues, whereas healing tissue contains areas of periodontal regeneration and repair and not necessarily a gain in attachment. We'll see about regeneration in detail. Regeneration is defined as a natural renewal of a structure produced by growth and differentiation of new cells and intercellular substances to form a new tissues or part. Gingival epithelium is replaced by epithelium, which is connective tissue, and periodontal ligament is by connective tissue, which is undifferentiated connective tissue cell develop into osteoblast to form bone and cementoblast to form cementum. Repair is simply restores the continuity of the diseased marginal gingiva and re-establishes a normal gingival sulcus at the same level on the root at the base of the pre-existing periodontal pocket, which is arrest bone destruction, no gain in height of the bone, no gain in attachment of the gingiva. Repair occurs when periodontal reconstructive surgery is not done or not successful. Okay. Possible wound healing patterns of a periodontal structure is depends on one is repair and regeneration. Repair by long junction epithelium, connective tissue adhesion and root resorption and ankylosis. Regeneration is by new connective tissue attachments. Okay. From this picture, we can able to differentiate between regeneration and repair. Repair is by long junction epithelium, connective tissue adhesion, and root resorption, and finally root resorption and ankylosis. Regeneration by means of new connective tissue attachments. We'll see about new attachment and reattachment. New attachment is something which is embedding of new periodontal ligament fiber into a new cementum and the attachment of gingival epithelium to the tooth surface previously denuded of the disease. Reattachment refers to repair in the areas of root not previously exposed to the pocket. After surgical detachment of the tissue or following traumatic tears in the cementum, tooth fractures or treatment periapical lesions. Okay, we'll see the fourth method to employ to quantify tissue changes due to regenerative techniques or products. One is clinical evaluation of attachment level and soft tissue parameters. Second one is clinical evaluation of hard tissue changes. Third one is radiographic evaluation of radiographic changes. And fourth one is histological analysis. Periodontal reconstruction is the one which, as I already told, the process of regeneration, which is rebuilding the periodontium to result in attachment of gain in attachment level, formation of new periodontal ligament fibers, level of alveolar bone, which is significantly coronal to the that present before treatment. Reconstructive surgical technique is divided into non-bone graft associated new attachment technique and bone graft associated new attachment technique. In non-bone graft associated new attachment technique, we have the technique for removal of junction and pocket epithelium and the prevention of their migration into the healing area after biotherapy. And second one is root conditioning, which is bioconditioning of the root surfaces. And we'll see the bone graft associated technique. One is autogenous bone graft, bone from the intraoral side, bone from the extraoral side. Allograft, which is DFDBD, DFDB, which is decalcified freeze dried bone allograft, and undecalcified freeze dried bone allograft. And xenograft is obtained from bovine, which is bovine derived. Example is bioas. New bone graft materials, which is taken up from dura, sclera, cartilage, bioactive glass. Examples are hydroxyapatite and tricalcium phosphate. We'll see the outcomes of surgical therapy. One is probing measurement and radiographs. Surgical re-entry shows increase in bone volume. Disadvantage is that it cannot show the presence of periodontal ligament between the tooth, between bone and tooth surface, which is indicative of new attachment. We'll see the terminologies in now. Osteogenesis, viable osteoblast within grafted material deposit new bone. Osteoconduction is bone graft material act as a scaffold for new bone formation. Osteoinduction, new bone is induced to form through the use of BMPs and growth factors. Osteopromotion is something which is material does not have osteoinductive property itself, but enhance osteoinduction by promoting bone formation. Example, enamel matrix derivative, which does not stimulate de novo bone formation alone, but when used with Demineralized freeze-dried bone graft, they enhance osteoinductive capacity. Autografts. Autografts is harvested from the patient's own body, which has the property of osteoconductive, osteoinductive, and osteogenesis. The advantage is that there is no risk of disease transmission because we are getting it from the same patient. It has two: one is cancellous revascularization, which contains viable cells, and cortical, which acts as a scaffold. Hence, it provides good stability. Corticocancellous is something which has both the properties of cancellous as well as the cortical bone. Autogenous bone graft, the most common site which we as an intraoral sources, edentulous area, maxillary tuberosity, extraction sites, healing bone wound, mental bone and retromolar areas. Cortical bone chips, which is shavings of the cortical bone, removed by chisel during osteoplasty and osteectomy. Disadvantage is that large size cannot be obtained from this bone graft. In autograft, there is something called osseous coagulum, bone particle harvested using round burr and mixed with blood. It provides osteoprogenitor cells and stable blood clot formation. Bone blend is something which is the collection of cortical and cancellous bone using trephine or rongers, which is placed into the amalgam capsule, and finally it is triturated to achieve osseous bone consistency. Bone swaging. Bone swaging is something which is taken up from the edentulous area adjacent to the defect, and the bone is pushed into contact and with root surface without fracturing bone at the base. Allograft. Allograft is obtained from the genetically dissimilar members of the same species, which is of two forms. One is freeze-dried bone allograft, and which has an osteoconductive scaffold. DFBDA is osteoconductive plus osteoinductive. Okay, why we need to decalcify and demineralize? Okay, demineralization or decalcification improves osteoinductive potential by exposing BMPs, which is thus results in increased bone formation. We'll see the xenograft. The three main sources of xenograft is bovine origin, porcine origin, and coralline calcium carbonate. Okay, which has an osteoconductive property. The processing is something they are anorganic, which means all inorganic content is removed to reduce chances of graft rejection. Okay, we'll see the bone substitute, which is synthetic variants alloplast. Synthetic variant alloplast are something which is derived from the corals, from the seas. Artificial bone can be created from ceramics such as calcium phosphate, porous hydroxyapatite tricalcium phosphate, bioglass, and calcium sulfate, all of which are biologically active, which is different degrees depending upon the solubility in the physiological environment. Hydroxyapatite is crystalline calcium phosphate, which has slow resorption. Biomodification of root surface. Changes in the tooth surface wall of the periodontal pocket that interface with the new attachment or the accumulation of bacteria and their products. Disintegration of cementum and dentine, degeneration of the remnants of Sharpie's fiber. These obstacles can be eliminated through root planing and biomodification such as root conditioning. Root conditioning materials such as citric acid, fibronectin, tetracycline. New approaches to periodontal regenerations are emdogain, which is commercially available obtained from the developing porcine teeth. After demineralization of the root surface with citric acid at 24% EDDA for 15 seconds, endogain gel is delivered by syringe to the defect site and the wound is sutured. Okay. These are the emdogain pictures, which means 3 units of 0.3 ml is used. Prefgel 3 pipettes of 1 ml. Intrabony defect treated with emdogain, tricalcium phosphate, and GTR. As we can easily appreciate from the picture, the first picture shows increased probing depth, followed by the bone loss. After treatment, we can able to appreciate the difference in levels of bone which has gained after using emdogain. Periodontal regeneration by means of using emdogain is considered to be a best for regeneration procedures. Biological mediators such as growth factors. Growth factor examples are, as we all know, PDGF, IGF, basic fibroblast growth factor, bone morphogenetic proteins, and transforming growth factors. Okay, we'll see PRPs, which is most commonly used nowadays to treat certain conditions. Autologous bone is drawn from and separated into three fractions, which comes as platelet poor plasma, platelet rich plasma, and RBCs. Fibrin formation is due to clot and which stabilizes the wound. Okay. As we can see from the picture, the red blood cell is settled down in the bottom, followed by the buffy coat, which has platelet and WBCs, and platelet poor plasma, as we can see in the upper part. From the second picture, we can able to differentiate the fibrin, which is obtained from the PRF. Okay, the bone defect is has gained attachment from the picture. From the first picture, it is shown to cause extreme bone loss in the middle third of the tooth. Okay, after treatment with platelet-rich plasma and platelet-rich fibrin, we can able to appreciate the bone loss has gained from the second picture. Okay, similarly, recession coverage procedure has also resulted a good with respect to platelet-rich fibrin. Okay, we'll see the other one, which has a group of regulatory glycoprotein, which is bone morphogenetic protein, which is a members of TGF beta superfamily, primarily stimulate differentiation of mesenchymal cells into chondroblast and osteoblast. Histological analysis revealed periodontal regeneration with area of ankylosis. Most of the research has involved its effect in stimulating new bone formation through GBR before or in conjunction with implant placement, where ankylosis is of prime concern. Okay. Finally, a gene therapy for correcting periodontal defect. A new approach to deliver growth factor. Growth factor once supplied are subjected to proteolytic breakdown, receptor binding protein problems, and is dependent upon the stability of the carrier system. So gene therapy can be used for external extended local delivery of these factors. Uh, Gene delivery of platelet-derived growth factor stimulated more cementoblast activity than a single application of PDGF. Combined technique is by means of using graft material, root conditioning, and covered with non-resorbable membrane. Autogenous bone with resorbable membrane coverages includes successful new attachment and periodontal reconstruction. Criteria for this technique is first, we need to identify the dimension and morphology of the defect, number of walls in the defect, the amount of root surface exposed, and ability to obtain adequate flap coverage, and finally angle of the defect to the long axis of the tooth. Clinical decision based on the criteria which we seen. For deep, well-contained defects, use emdogain alone with coronally displaced flap if necessary. For moderate to deep, non-contained defects, use emdogain plus graft with coronally advanced flap if necessary. For supracrustal defect with shallow vertical defects, use emdogain plus graft plus barrier membrane with coronally advanced flap. Okay. I concluded by saying that periodontal regeneration continues to be one of the primary therapeutic approaches towards the management of periodontal defect. By means of using certain periodontal regeneration procedure, we can able to achieve good treatment levels, which is we can able to increase the bone level with the use of newer generation PRFs like that. The clinician must be carefully evaluate the various regenerative and reparative approaches and then decide which technique may result in better outcomes. Thank you.